Of all the domains in which I have traced the consequences of social capital, in none is the importance of social connectedness so well established as in the case of health and well-being. Scientific studies of the effects of social cohesion on physical and mental health can be traced to the seminal work of the 19th century sociologist Emile Durkheim, Suicide. Self-destruction is not merely a personal tragedy, he found, but a sociologically predictable consequence of the degree to which one is integrated into society, rarer among married people, rarer in more tightly knit religious communities, rarer in times of national unity, and more frequent when rapid social change disrupts the social fabric. Social connectedness matters to our lives in the most profound way. In recent decades, public health researchers have extended this initial insight to virtually all aspects of health, physical as well as psychological. Dozens of painstaking studies from Alameda, California, to Tecumseh, Michigan, have established beyond reasonable doubt that social connectedness is one of the most powerful determinants of our well-being. The more integrated we are with our community, the less likely we are to experience colds, heart attacks, strokes, cancer, depression, and premature death of all sorts. Such protective effects have been confirmed for close family ties, for friendship networks, for participation in social events, and even for simple affiliation with religious and other civic associations. In other words, all enjoy these remarkable health benefits. After reviewing dozens of scientific studies, sociologist James House and his colleagues have concluded that the positive contributions to health made by social integration and social support rival in strength the detrimental contributions of well-established biomedical risk factors like cigarette smoking, obesity, elevated blood pressure, and physical inactivity. Statistically speaking, the evidence for the health consequences of social connectedness is as strong today as was the evidence for the health consequences of smoking at the time of the first Surgeon General's report on smoking. Although researchers aren't entirely sure why social cohesion matters for health, they have a number of plausible theories. First, social networks furnish tangible assistance, such as money, convalescent care, and transportation, which reduces psychic and physical stress and provides a safety net. If you go to church regularly and then you slip in the bathtub and miss a Sunday, someone is more likely to notice. Social networks also reinforce healthy norms. Socially isolated people are more likely to smoke, drink, overeat, and engage in other health-damaging behaviors. And socially cohesive communities are best able to organize politically to ensure first-rate medical services. Finally, and most intriguingly, social capital might actually serve as a physiological triggering mechanism, stimulating people's immune systems to fight disease and buffer stress. Research now underway suggests that social isolation has measurable biochemical effects on the body. Animals who have been isolated develop more extensive atherosclerosis, hardening of the arteries, than less isolated animals, and among both animals and humans, loneliness appears to decrease the immune response and increase blood pressure. Lisa Berkman, one of the leading researchers in the field, has speculated that social isolation is a chronically stressful condition to which the organism responds by aging faster. Some studies have documented the strong correlation between connectedness and health at the community level. Others have zeroed in on individuals, both in natural settings and in experimental conditions. These studies are for the most part careful to account for confounding factors, the panoply of other physiological, economic, institutional, behavioral, and demographic forces that might also affect an individual's health. In many cases, these studies are longitudinal. They check on people over many years to get a better understanding of what lifestyle changes might have caused people's health to improve or decline. Thus, researchers have been able to show that social isolation precedes illness to rule out the possibility that the isolation was caused by illness. Over the last 20 years, more than a dozen large studies of this sort in the United States, Scandinavia, and Japan have shown that people who are socially disconnected are between 2 and 5 times more likely to die from all causes, compared with matched individuals who have close ties with family, friends, and the community. A recent study by researchers at the Harvard School of Public Health provides an excellent overview of the link between social capital and physical health across the United States. Using survey data from nearly 170,000 individuals in all 50 states, these researchers found, as expected, that people who are African American, lack health insurance, are overweight, smoke, have a low income, or lack a college education, are at greater risk for illness than are more socioeconomically advantaged individuals. But these researchers also found an astonishingly strong relationship between poor health and low social capital. States whose residents were most likely to report fair or poor health were the same states in which residents were most likely to distrust others. Moving from a state with a wealth of social capital to a state with very little social capital, low trust, low voluntary group membership, increased one's chances of poor to middling health by roughly 40–70%. The researchers accounted for individual residents' risk factors. The relationship between social capital and individual health remained. Indeed, the researchers concluded that if one wanted to improve one's health, moving to a high social capital state would do almost as much good as quitting smoking. These authors' conclusion is complemented by our own analysis. We found a strong positive relationship between a comprehensive index of public health and the social capital index, along with a strong negative correlation between the social capital index and all-cause mortality rates. State-level findings are suggestive, but far more definitive evidence of the benefits of community cohesion is provided by a wealth of studies that examine individual health as a function of individual social capital resources. Nowhere is the connection better illustrated than in Roseto, Pennsylvania. This small Italian-American community has been the subject of nearly 40 years of in-depth study, beginning in the 1950s, when medical researchers noticed a happy but puzzling phenomenon. Compared with residents of neighboring towns, Rosetans just didn't die of heart attacks. Their age-adjusted heart attack rate was less than half that of their neighbors. Over a 7-year period, not a single Roseto resident under 47 had died of a heart attack. The researchers looked for the usual explanations: diet, exercise, weight, smoking, genetic predisposition, and so forth. But none of these explanations held the answer. Indeed, Rosetans were actually more likely to have some of these risk factors than were people in neighboring towns. The researchers then began to explore Roseto's social dynamics. The town had been founded in the 19th century by people from the same southern Italian village. Through local leadership, these immigrants had created a mutual aid society, churches, sports clubs, a labor union, a newspaper, scout troops, and a park and athletic field. The residents had also developed a tight-knit community where conspicuous displays of wealth were scorned and family values and good behaviors reinforced. Rosetans learned to draw on one another for financial, emotional, and other forms of support. By day they congregated on front porches to watch the comings and goings, and by night they gravitated to local social clubs. In the 1960s, the researchers began to suspect that social capital, though they didn't use the term, was the key to Rosetans' healthy hearts. And the researchers worried that as socially mobile young people began to reject the tight-knit Italian folkways, the heart attack rate would begin to rise. Sure enough, by the 1980s, Roseto's new generation of adults had a heart attack rate above that of their neighbors in a nearby and demographically similar town. The Roseto story is a particularly vivid and compelling one, but numerous other studies have supported the medical researchers' intuition that social cohesion matters, not just in preventing premature death, but also in preventing disease and speeding recovery. For example, a long-term study in California found that people with the fewest social ties have the highest risk of dying from heart disease, circulatory problems, and cancer in women, even after accounting for individual health status, socioeconomic factors, and use of preventive health care. Other studies have linked lower death rates with membership in voluntary groups and engagement in cultural activities, church attendance, phone calls and visits with friends and relatives, and general sociability, such as holding parties at home, attending union meetings, visiting friends, participating in organized sports, or being members of highly cohesive military units.